Alright guys, now that you had a chance to stretch your legs and take a break, we're going to pick up with airway and respiratory problems seen within the pediatric patient. Now if you remember back to us talking previously, one of the main leading causes of cardiac arrest within the pediatric patients is due to respiratory failure. They have choked on something, or they have a viral infection that has progressively gotten worse, um, and they'll be able to compensate for it very well until they're no longer able to. Once they have exhausted is when they go into respiratory failure, cardiac failure, and eventually go into arrest. When they are having early respiratory distress, this is still a serious problem. The patient can regress from early compensated respiratory distress to decompensated respiratory failure and respiratory arrest within minutes. So even if they are in respiratory distress, we still want to treat them very aggressively. Usually at this point, they'll still have adequate respirations. Their work of breathing may be slightly increased, but still want to provide them with oxygen and transport them expeditiously to the hospital. We may also encounter an infant or child in decompensated respiratory failure. As the name implies, the infant or child is failing to compensate for the impaired respiratory condition and cannot maintain their own adequate breathing. At this point, either the respiratory rate or the tidal volume has become inadequate, and the infant or child requires immediate intervention. In addition, patients in respiratory failure could potentially have a respiratory rate greater than 60. You might see signs of cyanosis within their distal extremities and around their oral mucosas, their decreased muscle tone, their accessory muscle usage. If any of these signs are present, we need to provide positive pressure ventilation with a BVM or some other acceptable ventilation device, and provide supplemental oxygen and immediately transport to the hospital. And also we need to request for ALS. When they have gone into respiratory arrest, this is when they're pretty much, if they haven't already, they've stopped breathing. These patients will have a respiratory rate less than 10. They may have agonal respirations. They will appear to be limp, hypotensive. Their pulses may be weak or even absent. And they will be unresponsive as well. With a partial airway obstruction, these patients may be alert with decent peripheral perfusion. Their skin may be normal or slightly pale, and you might hear some stridor. If the patient displays the signs just listed and still maintains an adequate respiratory volume, general treatment principles include allowing the patient to assume a position of comfort, except for laying the patient down. Enlist the help of the parents or caregivers while you administer oxygen. Encourage the patient to cough if a tangible obstruction is present, and limit your examination so as not to further agitate the patient, and transport the patient immediately to the nearest hospital. With a complete airway obstruction, now the trachea has become completely occluded. With these patients, they won't be able to cry, they won't be talking, their breathing, if they have a cough, it's now become ineffective. It'll look like they're trying to cough, but nothing's coming out. Cyanosis, if it hasn't developed, will soon develop. These patients are going to need some type of aggressive treatment to try to relieve that airway obstruction. Either if they're still alert, what are we going to do? Right, we're going to provide the Heimlich maneuver. If they are unresponsive, what are we going to do? Right, we're going to start CPR, and what addition are we going to do? Right, we're going to look for the obstructing airway before providing breaths. Another thing that we want to take into consideration is once EMS has arrived, if they've gone unresponsive, something that they might do is what's called a direct laryngoscopy, and where they actually look and try to see if they can find the object and remove it that way. However, that is a paramedic skill. If you go on through medic, we will learn how to do that. Make sure that you're able to maintain your patent airway with these patients. If there's no C-spine injury suspected, we'll do the head tilt chin lift. If it is suspected, we're going to use the jaw thrust maneuver, but remember to provide padding behind the shoulders to keep everything in line. When suctioning, the whole process of suctioning temporarily prevents air from being breathed into the lungs. When suctioning an infant or child, do not suction any longer than 3 to 5 seconds at a time, so as not to promote hypoxia or cause a profound bradycardia due to vagal stimulation. We want to make sure that we are using equipment that is properly sized for the patient. We don't want to risk putting something in too big and causing further injuries. If the child is unresponsive and there's no gag reflex, we can consider inserting a oropharyngeal airway or OPA in. If they are unable to tolerate an oral airway, we want to consider using a nasopharyngeal airway or an NPA. However, if there's a possibility of head trauma, nasopharyngeal airways should be avoided in these patients. Because children are prone to having adenoidal hypertrophy, nasopharyngeal airways can core out adenoid tissue, resulting in significant upper airway bleeding that is difficult to control. In general, nasopharyngeal airways should be avoided in children, and especially in infants whose nares are so small in diameter that the airway resistance created by the small diameter of the nasopharyngeal is too great to make breathing through it effective. If the child or infant is in decompensated respiratory failure or respiratory arrest, that is with inadequate breathing or not breathing, you should start positive pressure ventilation using a bag valve mask device or a pocket mask. Supplemental oxygen must be attached to the device as soon as possible. The infant or child patient should also be ventilated at a rate of 20 to 25 breaths per minute. Breathe into the pocket mask or squeeze the BVM device slowly and evenly to ensure adequate chest rise. Remember, 1 breath over 1 second. If regurgitation is becoming a problem, you can also consider applying cricoid pressure that could potentially help prevent the regurgitation from occurring. If the patient is breathing adequately but has other signs of early respiratory distress, administer oxygen to maintain an SpO2 of 94% or greater. If the patient cannot tolerate the nasal cannula or mask, you can consider using a blow-by method. If the patient is presenting with respiratory distress and altered mental status, you want to provide positive back valve mask ventilations with supplemental oxygen. Cyanosis, present with a bite oxygen via non-breather. Respiratory distress with poor muscle tone, and if they are in respiratory failure or in respiratory arrest. Patients who are in mild respiratory distress would probably prefer to sit in the lap of their caregiver. If the patient is unresponsive, place them in a lateral recumbent position to help prevent aspiration, and make sure that you have suction available. If the patient requires ventilation, they must be kept in a supine position. It also may be necessary to provide spine motion restriction for the infant or child to prevent possible aggravation of an existing spinal injury. The key in providing spine motion restriction for the infant or child patient is to place a folded towel or some other type of similar item beneath their shoulder blades to help keep the head from flexing forward. And then we want to transport the patient. Any pediatric patient with a respiratory complaint or with evidence of respiratory distress needs to be transported to an appropriate medical facility for further evaluation. Preferably a children's hospital or a hospital that has practitioners who are specialized with dealing with pediatric patients. If you notice a high resistance to airflow after initiating positive pressure ventilation on a patient with respiratory failure or respiratory arrest, attempt to reposition their airway and reventilate. If after repositioning, the airway is still not patent and there's no indications that the child is suffering from an illness, assume the infant or child has an airway obstructed by a foreign body and begin treatment for such. In an infant or child with a mild foreign body airway obstruction, if a foreign body is suspected and is not caused by an airway infection, we need to provide actions to clear their airway, such as doing the Heimlich maneuver, or providing CPR if they have gone unresponsive. Do not perform any intervention in a patient that has a mild obstruction. However, if they, such as they're coughing, if they are coughing, let them continue to cough. If at any time they no longer are making any sounds or coughing, this is when they've developed that severe airway obstruction. We need to react very quickly to remove it. You must constantly and closely assess the infant or child with a mild obstruction for signs of development of that severe obstruction. If they are not going to allow you to place a mask or nasal cannula directly on them, we don't want to agitate them too much because that could cause the obstruction to completely occlude their airway. So we can just provide blow-by oxygen to the infant or child to maintain an O2 sat of 94% or greater. If they have gone unresponsive, if they are still responsive, we want to take our steps per AHA guidelines to remove the obstruction. So we're going to deliver 5 back blows followed by 5 chest thrusts. We're going to repeat until the obstruction has become completed or relieved. They go unresponsive, or you arrive at a medical facility. If they have gone unresponsive, we need to initiate our treatment for it. So we're going to start providing CPR, and each time before we provide a set of ventilations, we need to look into their airway and see if we can see the obstructing object. And we're going to continue to do this until the object has been removed. If it cannot be visualized, or if you cannot reach it and remove it, continue chest compressions and attempted ventilations. In the child, this is when we're going to provide the Heimlich maneuver. In the severe foreign airway obstructions, those over to the age of 1. If they've gone unresponsive, same thing. We're going to lower them down to the ground. If we can see the object, we want to attempt to remove it. If not, start CPR before providing ventilations, we need to check to see if we can see the obstructing object. If we, after removing the object, you still need to check to see if they have a pulse. If they do not have a pulse, continue CPR. If they still have a pulse, assess of whether or not they are breathing on their own. Excuse me. Croup is a very common infection of the upper airway. Usually this is caused by some type of virus. However, it can sometimes be caused by a bacterial infection as well. It has a very slow onset of its symptoms, and it's usually accompanied with a low-grade fever. This is usually seen in children between the ages of 6 months and 4 years of age. This is when they're presenting with the seal bark-like crowing cough, and what's happening is it has that infection and it's causing swelling of the epiglottis. So this is where that swelling is occurring, and the epiglottis is now not able to close appropriately over the trachea. So now not only is the child have chance of their airway a higher chance of becoming occluded, they have a higher chance of, they have an increased likelihood of aspirating as well, because now the epiglottis cannot completely close off the trachea. With these patients, we want to administer oxygen. If possible, we want to provide humidified oxygen to maintain an O2 sat of at least 94%. Try to keep them comfortable. Don't agitate them. And because if you agitate them, or if you give them something by mouth even, it can cause the epiglottis to close up. With epiglottitis, this is a condition that resembles croup. However, it's caused by a bacterial infection that inflames the epiglottis and causes swelling of the epiglottis. Epiglottitis is life-threatening if left untreated, has a 50% mortality rate. The difference between epiglottitis and croup is that this has a very rapid onset of symptoms, and it's accompanied by a very high temperature. These patients will, usually between the ages of 2 to 7, they will present with pain, swallowing. They'll look very ill. They'll be drooling, they'll be breathing through their mouth. It'll hurt when they try to speak. With this, because the swelling of the epiglottis is more severe, so they're going to have some inspiratory stridor. They're going to thrust their chin and neck outward to try to open up that airway as much as they can, so that way they can breathe properly. You do not want to give these patients anything by mouth. Same thing with croup. We want to keep them comfortable, try to keep them calm, provide oxygen however we can to maintain an O2 sat of at least 94%. And also you want to consider getting ALS backup. If you can't get ALS on scene, we need to rapidly transport the patient. Asthma is a long-term inflammatory process that usually targets the lower airways. The inflammation is characterized by causing an increased production of mucus within the airway, and also causing acute narrowing of the airways through inflammation of airway tissue, thus leading to edema or swelling within the airways. These patients the common symptoms of asthma usually include shortness of breath, some chest tightness and wheezing, and a non-productive cough. Although the questions listed are not all the questions that we're going to ask, these are some that can help us gauge the severity of the attack, such as how long have they been wheezing, do they have any medication for this attack, what is it, have they taken it, when do they take it, how much do they take, are they allergic to anything that you're aware of, have they taken anything new, or they've been exposed to anything new that they could have caused them to have an asthma attack. While going through your assessment, we want to look at their position. Are they tripoding? Are they bobbing? Um, How's their mental status? What's their vitals? Uh, what's their skin color and condition? Are they pale? Are they flushed? What's their respiration status like? Are they breathing faster than normal? Care for this patient is we want to try to maintain an O2 sat of 94. If the patient has prescribed inhaler, we want to provide that to them. If their condition continues to deteriorate, we want to consider initiating positive pressure ventilation. Consider calling for ALS and transport to the emergency department. If you've attempted providing medication and the asthma attack continues to become more and more severe, this is what's called status asthmaticus, and this is a serious life-threatening condition. Bronchiolitis is infection of the bronchioles and is caused by a viral infection and is often called RSV. These patients will present with wheezing and other signs similar to that of asthma, but they'll have a low-grade fever about 99 to 100 degrees. Usually this will be seen in patients less than 2 years of age. Care for these patients, try to maintain an O2 sat of at least 94. Keep them comfortable, watch their vitals and mental status. If their condition deteriorates, start PPV, transport, and consider calling for an ALS intercept. Pneumonia is caused by an infection to the lungs that obstructs the airways and could potentially lead to respiratory compromise. Pneumonia is estimated to cause approximately 4 million deaths among children worldwide. In the United States from 1939 to 1996, mortality caused by pneumonia in children declined by up to 97%. This decline is most likely attributable to the introduction of antibiotics, vaccines, improvements in medical care, and the expansion of medical insurance coverage for children. Pneumonia can involve a bacterial, a viral, mycoplasmal, and even fungal infection of the lung. These patients will present with shortness of breath, breath sounds that are diminished in one or both lungs, a productive cough, potentially, as well as chest tightness. With this, we want to look at, as we go through our assessment, we want to look at their position. They may lie on their side with their knees drawn up or be in a tripod position. We want to look at their mental status. Or do they appear drowsy? They also may have intermittent periods of restlessness. Look at their skin, looking for evidence of dehydration or cyanosis. Look at their vital signs, as well as their respirations. Care for these patients is going to be like most other respiratory issues. We want to try to maintain an O2 sat of at least 94%. Keep them comfortable. Transport. Consider calling for ALS. And if the patient's condition deteriorates, initiate positive pressure ventilation. Congenital heart defects are responsible for more deaths in the first year of an infant's life than any other birth defect. The initial presentation of the infant with congenital heart defects can be inconsistent, looking like respiratory distress or infection, failure to thrive, and even shock. This can be caused by an abnormal valve, such as mitral valve prolapse, issue with vessels, or even the chambers of the heart itself. Because the defect can be due to abnormal valves, vessels, or chambers, diagnosing the defect is less important than recognizing the abnormality on assessment, initiating emergency care, and transporting rapidly to an appropriate medical facility. Caring for these patients, just support. Try to support their cardiovascular system as much as you can. Monitor their O2 sats to maintain a sat of at least 94. And transport immediately and consider ALS backup or intercept. Beyond that, there's not much that we can do other than support any lost function. Shock, this is caused by there's some type of hypovolemia, obstruction, distributive, or cardiogenic shock. These patients will usually can be caused by diarrhea, dehydration, trauma, blood loss, infection, or some type of abdominal injury. These patients may present with respiratory rate, weak or absent peripheral pulse, delayed cap refill, pale, cool, clammy skin, or impaired mental status or complete unresponsiveness. Caring for these patients, we want to try to maintain an open airway to maintain an O2 sat of at least 94%. Provide positive pressure ventilation. If there's any bleeding, we want to try to control it. Keep them supine and warm. And transport them rapidly and consider calling for ALS. With cardiac arrest, remember that most cardiac arrests in children are due to some type of airway obstruction or respiratory distress leading up to respiratory arrest. So we want to aggressively manage them. Obviously, we're going to start CPR, but we also want to go through and look for any kind of respiratory issues that may have caused them to go into this issue. Our goal is to try to keep the brain viable. Standing orders that provide for orderly direction of treatment, easy access to paramedic backup, and continuous assessment are important. Unless too much time has elapsed between the arrest and initiation of artificial ventilation, the child may recover with minimal to no neurological deficit, even following comparatively long periods of arrest. So we're going to provide positive pressure ventilation, CPR, use an AED, ALS, and rapid transport. Alright guys, stop, take a break here. If you need to use the restroom, stretch your legs, anything, go get something to drink. You can do that at this time. And when we come back, we will pick up with some other conditions and emergencies that would be affected with children.